Welcome back to the Curbsiders. I'm Dr. Matthew Watto, here with my great friend, Dr. Paul Nelson Williams. We're going to be talking a little about how to wisely order, I guess we should say wisely ordering the ANA, Paul. We talked to a rheumatologist, Dr. Matt Carroll, at one of the big national conferences this year. And Paul, ANA, I just ordered on everybody. I like the order set that just shotguns a million labs. Is that the way to go, or why isn't that the way to go?
Yeah, no, I love me a fatigue order set, as already noted, with like Lyme serologies and the ANA in there, just to really confound things. Yeah, it's the ANA. It's the bane and the blessing, I guess, of rheumatologists. I feel like we often order it as primary care doctors as like this Hail Mary pass to see if it will kind of reveal something without having that something in mind. And the reason we do that is because it's cheap, it's easy, it's a blood draw. And sometimes the number comes back abnormal enough that you're like, all right, I found something, maybe question mark. But it turns out a good percentage, like I think 13% of the population, is just going to have a positive ANA without actually having underlying rheumatologic disease, which is an issue. And then I also think, we've talked about before about how, what do you do with an ANA of like 1 to 40, which is positive technically, but not that positive. And our guest talks about how that number really doesn't excite him. And it's not until you get to like the 1 to 160 or the 1 to 320 that it really becomes noteworthy when you start to pay attention and put it together with the clinical picture to actually come up with something.
Yeah, the lupus guidelines from ACR, they have, or EULAR, they have a 1 to 80 as a requirement. You have to have at least a 1 to 80 positive ANA, but that's along with other features that actually make you think of lupus. And so, Paul, the big societies, have they made any statements about how we should think about ordering an ANA?
This is some excellent leading the witness, Dr. Watto. Yeah, it's the American, the British, and the Canadian Rheumatology Society, the Choosing Wisely guidelines, all recommend that you do not order an ANA for just fatigue or malaise or whatever, unless you have suspicion for lupus or connective tissue disease. Otherwise, just don't do it. And I that's probably wise advice, because I don't know what to do with it otherwise.
And there's a list of conditions that people can keep in mind that of non-rheumatologic conditions that have a positive ANA. So if those are present, that might explain it. So there's multiple sclerosis sometimes can have it. There's autoimmune hepatitis, autoimmune thyroid disease. What else am I forgetting here, Paul? Idiopathic pulmonary hypertension, primary biliary cirrhosis. So some of those things can have a positive ANA. And really, I think the way to go is think about the illness scripts, because there's about 5 conditions that we talked about on the episode that have a positive ANA. So it's like mixed connective tissue disease is one of them, and that's a mix of some of these other things that I'll mention. So scleroderma, lupus, idiopathic inflammatory myopathies, and then Sjogren's syndrome. So mixed connective tissue disease can be an overlap with features of some of those things. But scleroderma, think about that, Paul. In the patient, they might have digital pitting. They might have sclerodactyly, that thickened skin over their fingers. Raynaud's phenomenon, maybe interstitial lung disease, telangiectasias. I think lupus, people know to look for the malar rash, but they can also have a small joint arthritis. They might have nephritis and proteinuria, pleurisy. So lupus is on the differential, of course. And if you think of that, then maybe getting an ANA is appropriate. We talked about some of the myopathies on a previous episode. So people who have muscle weakness, heliotrope rash, like mechanic's hands, those kind of things. And finally, dry mouth and dry eyes, Sjogren's syndrome. And he said some of the ways he asked about that is like, have you had a lot of cavities? Are you constantly having to drink water even at night? There's a lot of reasons for that. But what else? You said use of, what were you saying?
A lot of eye drops too. Like if people are just using eye drops all the time, that can also sometimes be a giveaway, because sometimes patients, again, have compensatory behaviors. They may not even sort of recognize that.
Exactly. Yeah. So these are things. So think about that list. There's the things that could cause a positive ANA that aren't rheumatologic conditions, and then there's the 5 conditions that I just mentioned. And so think of those illness scripts and use that as a way to guide whether or not an ANA might be an appropriate test. Going back to episode 171, Paul, this is a pearl about lupus that I really liked from Dr. Beth Jonas. She said, if somebody has oral ulcers from lupus, they might not know it because they're actually painless. Compared to like aphthous ulcers, which are notoriously like very painful.
Yeah.
So always look, if you're suspecting lupus, you should look in the roof of the person's mouth to see if you see ulcers there. and you can think about proceeding with the testing if if your clinical suspicion is there based on the other things we talked about.
Right. The point being is, if this comes back positive, what specific disease am I concerned for that is not just, quote, something roomy?
Yeah.
Which had been my previous practice. So I'm happy to be able to hone things down a little bit.
Yeah. I don't blame people. And the Dr. Carroll he was really nice about it. He's like, and if you get yourself into one of these quagmires, just send them our way. We're happy to sort it out. I don't know how happy they are to sort it out, but I do appreciate that they are there for us when that does happen. So with all that, Paul, I should say this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Have I said you bet your sweet bippy yet, Matt? I feel like I probably have.
I think you might have said that.
It's one I like.
That's a good one. Well, until next time, I've been Dr. Matthew Frank Watto.
And as always, our main Dr. Paul Nelson Williams. Thank you and goodbye.